Good afternoon, everyone. We'll start the seminar now. If people want to get any drink or anything they want and sit down. Welcome to the 51st seminar on this Global Health Histories series. The title of the seminar today is Mobilizing Communities for Sexual, Reproductive and Maternal Health. As usual, we'll have two speakers who'll each give their presentations, and then we'll open it up for questions. Just to remind you that the seminar and the questions are being broadcast via the internet. So I'd like anybody to, when they speak afterwards for the questions, to speak to the microphone so that people can hear you. The seminars are also recorded and will be available later. And also when you speak, everyone to give their name so that people who are listening in know who is speaking. My name is Human Moman, and I'm from the Department of Knowledge Management and Sharing at the World Health Organization. So our first speaker this afternoon is Professor Cathy Campbell. She is the Professor of Social Psychology at the London School of Economics. She's author of many scientific papers, been actively involved in research in South Africa, Zimbabwe, India on this area of mobilizing communities, especially in AIDS work. She's recently been awarded a prize by the American Sociological Association for her work on this topic, and has recently authored a theme issue in the journal AIDS Care on the topic of community mobilization. So I'd like to ask Dr. Campbell to give the first presentation. Thank you.
Thank you very much. Thank you very much for having me. It's great to be here. The title of my presentation is Mobilizing Communities for Sexual and Reproductive Health Promotion. And as we're all aware, many biomedical and behavioral HIV/AIDS programs aimed at prevention, care and treatment have had disappointing outcomes because of a lack of effective community mobilization. Community mobilization is vital for various reasons for the success of programs. Firstly, it's a method of reaching otherwise inaccessible marginalized groups within which HIV/AIDS often flourishes. Secondly, it's part of a wider task-shifting agenda given the shortage of health workers, particularly in many low-income settings. Thirdly, and to me as a social psychologist most importantly, it's the best way of ensuring that health program goals and activities resonate with communities' own perceptions of their needs and interests, which is an essential precondition for optimal uptake of services. And finally, it's a pillar of efforts to ensure long-term sustainability of programs when donors are only able to be involved in a short-term kind of way. But as we're all aware, community mobilization is notoriously difficult to bring about. And while there have been successes in some limited countries and contexts, there have been just as many disappointments and failures. Elsewhere, I've argued one of the reasons for these failures is that too much attention is put on the challenges of building community-level AIDS competence, where people focus very narrowly on building AIDS awareness within communities and trying to build people's confidence to make more health-enhancing decisions. But too little attention has been paid to the challenge of building health-enabling social contexts, contexts which enable and support the likelihood that people will be able to put new health awareness and new health-related decisions into action. And so in my talk today, I want to map out some of those dimensions of social context that I think are vitally important if community mobilization efforts are going to succeed. My question is, what are the necessary contextual preconditions for community mobilization to succeed? It's not enough to focus, as most health programs do, just narrowly on their target communities. One also needs to see that wider support networks are in place. And it's not enough simply to focus on health in one's activities. One has to look more widely at the broader psychosocial dynamics within which the options and possibilities for health are embedded. Has it been just drifting away as I went? Let me just do the slide timings to get them right now, otherwise it's not going to work. Slideshow. Slide transition. My tool slides. Thanks. In my talk today, I'm drawing particularly heavily on a paper by myself and my colleague Flora Cornish, which is about to come out in the journal AIDS and Behavior. Flora is the person who did all the research on the Sonagachi project that I'm going to talk about today, whereas I did the research on the Itabeni project. So just to say that I'm not an expert on Sonagachi, and I'm drawing very heavily on Flora's inputs here. Okay. I'm going to argue my point using contrasting case studies, both of which use peer education as a starting point for community mobilization through involving highly marginalized women in efforts to manage HIV/AIDS. The Itabeni project in South Africa trained women volunteers in home nursing skills to assist people dying of AIDS. The project was a resounding success in relation to empowering women to provide very effective home nursing skills. But it was less successful in its efforts to use volunteers' involvement in home nursing as a springboard to their wider empowerment and their wider leadership of health issues in the community. And one of the aims of the project was that volunteers would, over a 3-year period, be empowered to take over the program so it would be sustainable once the donors had withdrawn, and this didn't happen. By contrast, the Sonagachi project in urban Kolkata in India began by mobilizing sex workers to promote HIV prevention amongst their peers through promoting awareness and distributing condoms. But in contrast to Itabeni, this health-related work served very successfully as the starting point for a wider process of empowerment of sex workers to take control of the project and to take control of their lives beyond the narrow confines of HIV prevention. The method that I've used, that Flora and I have used in the paper, is one of dichotomous case selection. And here I need to emphasize that I'm aware of the fact that these are very different contexts and projects, and that this paper is not intended as a comparison of the projects per se. We've simply chosen these programs as a springboard to a wider discussion about those features of context that enable community mobilization to exist, and to support our argument that unless community mobilization efforts pay much greater attention to the wider context of the programs, their chances of being successful are still substantially reduced. All right, so peer education. Both programs use peer education, the most widely used form of community outreach within health, I think internationally. Peer education assumes people are most likely to change health-damaging attitudes and behaviors when they see that liked and trusted peers are changing theirs. But this is not enough, so our starting point is that it's not enough to persuade people to make decisions to access services, to adhere to treatment and this and that. One also needs to provide enabling conditions to make this possible, what we call health-enabling social environments, social contexts that enable and support the possibility of health-enhancing attitudes and behavior change. All right, so we talk about 3 dimensions of context: symbolic, material, and relational. Let me go through each of these first quickly. What do we mean by symbolic context in which a program is inserted? We refer to the meanings, the ideologies, the worldviews through which people understand themselves, others, and the activities that they're engaged in. So, for example, the symbolic context frames how different groups are valued and respected. In some communities, gender ideologies would limit how men and women understand the potential of women to lead health projects and to play leadership roles in the community. We refer to 2 dimensions of material context. Firstly, resource-based agency, the access that particular groups will have to resources such as food, money, work, transport, and so on, all of which obviously enhance people's ability to access services and to use them properly. And the second understanding of material context relates to the existence or otherwise of concrete opportunities for previously marginalized groups to take health-related skills and to transfer them to other areas of their lives, both in their own lives and within the community. And in relation to relational contexts, the first of these that we focus on is the importance of the full participation of people in the leadership of health projects. And another key determinant of health project success relates to the ability of the project to mobilize bonding social capital, support networks within the community, and bridging social capital links with more powerful outside actors and agencies that have the power to assist a community health project in achieving its goals. Spivak highlights the fact that the big problem with community mobilization has been that we go into communities and assume that people are homogenous and have common interests in this and that. Okay, so the starting point of all community work needs to be that communities are full of groups with very conflicting needs and interests. They're men and women who see the world in a very different way, have very different access to power, motivation, young people and old people, you know, leaders and followers, and so on and so forth. And Spivak talks about the importance of building strategic alliances across very different community groups around very narrowly overlapping interests. And in this case, this would be HIV/AIDS management. So let me get on to my case study and start with the Sonagachi project. And as I say here, I draw on Flor's work. The project was initiated in 1992 with the remit of reducing the sexual transmission of HIV between sex workers and their clients in the largest red light district of Kolkata in India. Dr. Jana, an occupational health doctor from the All India Institute of Hygiene and Public Health, was given the task of establishing the project, and peer education and sexual health clinics formed its backbone. 12 sex workers were initially recruited to serve as peer educators who were to disseminate information about HIV transmission and prevention, promote condom use, and encourage sex workers to attend the project's sexual health clinic. However, as the project developed over time, its remit and the roles of its members changed, widening its focus to include far more opportunities for women to make political demands for wider social change to enable better life and better health. In 1995, a parallel sexual health intervention, the DMSC, was formed, aiming to unite sex workers very specifically to fight for their rights and to represent sex workers' interests in negotiations with more powerful groups. At the same time, sex workers were empowered to take on leadership roles within the project, and in 1999, the DMSC took over responsibility for the intervention. The project expanded its focus from clinic-based sexual health promotion to a wide range of social interventions, including the establishment of a cooperative bank for sex workers, advocating on sex workers' behalf in relation to the police, brothel managers, or exploitative local men, and influencing opinion leaders such as journalists and politicians. Positive outcome evaluations of the Sonagachi model claimed that it had led to increased condom use and decreases in sexually transmitted infections, and it's come to serve as a role model project both in India and beyond. And Cornish emphasizes, today we're going to talk about the positive aspects of the project, but she emphasizes that the very positive public face of the project doesn't incorporate its complicated dilemmas, challenges, and problematic experiences. Some people claim that the project is more dependent on its leader and less completely generated by grassroots sex workers than it would claim, and so on and so forth. But I'm not going to get into that. What I'm looking at is really some of the factors that have enabled the very real successes that the project did achieve. Then let's look at the Entabeni project in rural South Africa, established by an alliance between health volunteers and local women in a South African rural community, and HIVAN, a university-based NGO located 2 hours drive away that I was part of. Entabeni has minimal access to roads, electricity, clean water, formal health facilities, 35% of pregnant women HIV positive. Residents survive through subsistence farming in a rocky area with frequent drought. A traditional chief governs the area, power very much in the hands of adult men. There's no time for me to go into the history of the program, but just quickly to say that HIVAN was invited to support a pre-existing indigenous community group. So this was a home-based care initiative that had been started by local women and had run quite successfully, but was floundering at this particular moment. And they realized that unless they got some outside help, they weren't going to be able to continue their work. The main support for people dying of AIDS in Entabeni were volunteer women working without training, payment, or recognition from local community residents, public sector health and welfare departments, or NGOs. And this project had 3 strategies. The first one, which is a standard one for a community mobilization project, was to strengthen existing community skills, and the volunteers were very clear about the skills that they needed, things like how to manage people with bed sores in conditions where there was no water or access to bed linen and so on, things like bereavement counseling, things like supporting people in accessing welfare grants and so on. But the project had 2 more aims, and this is where we get to the contextual bits. Firstly, to strengthen local support structures for volunteers, the recognition and support for their work, and also to build partnerships with outside agencies in the public and NGO sectors, which will be vital for the sustainable long-term project management to continue after the 3-year funded period is over. And how did the project do in this? The first part was very easy. Over 3 years, the project's peer education component trained volunteers in counselling, home nursing, assisting people to access grants and so on. They did so in a cascade system so that these skills spread throughout the community. It increased the profile of the volunteers, the effectiveness of their service. A lot of home nursing support was given to completely unsupported families in all sorts of very positive ways. And the project had some success in mobilizing the participation of church leaders. It was less successful, however, in mobilizing the support of local traditional leaders and men, the most powerful groups in the private and public spheres in the community. It also had little success in mobilizing young people, originally anticipated to form the pool of new volunteers with high levels of unemployed young people and young people out of school. The project's 2 key disappointments, which it really did founder on, were firstly its inability to mobilize the long-term commitment of external partners in the health and welfare departments and the municipal structures. The second department was its failure to organize payment for the volunteers. Because despite ongoing government promises that volunteers would eventually receive a stipend, Highbank's efforts to secure this was unsuccessful. The government kept on moving the goalposts. So I think women were highly motivated to volunteer because they thought eventually they'd get the stipend. Then the government said the stipends are coming. Then the government said, no, well, the stipends are in fact only going to go to people who have a matric school living certificate, which excluded most of these women. But then even that small group of women that did have the school leaving certificate got together and went to claim the stipends, and they said, no, you've got to establish an NGO, and they just didn't have the structural facilities to establish an NGO. So this was an ongoing disappointment that undermined the progress of the project throughout its life. All right, so both projects managed to empower their respective marginalized communities, beginning with the technical skills of peer communication, but with an ethos that wider social change was needed, in the form of helpful networks with powerful groups, improved access to resources, more cohesive relationships within the communities. Both sought to promote grassroots ownership of the project and build the organizing skills of their grassroots group beyond peer education, in activities including chairing meetings, producing reports, and working with external stakeholders. What factors enabled Sonagachi to succeed where Entebeni failed? Let's look first at both projects' efforts to create supportive symbolic contexts. In both cases, women, sex workers and volunteers occupied a highly stigmatized position, which stood in the way of the project goals of community ownership, effective communication with community, and establishing the community's legitimacy in the eyes of potential external partners. Entebeni grappled with 3 forms of stigma which it never really managed to overcome. There was the stigmatization of AIDS as immoral and shameful, and despite the project's huge efforts to create less destructive attitudes to people with AIDS, promoting awareness, facilitating safe social spaces for people to look at fear and denial, lobbying for better services, building local confidence in people's agency to tackle a problem. It had little impact. The second form of stigmatization was the stigmatization of caring, which was widely regarded, particularly by men and young people, who should have been 2 key project constituencies, as women's work. They said, well, this is just the work that women does. It wasn't highly valued. And finally, highly stigmatized with the notion of volunteering, where people, and again, particularly men and young people, would sneer at the women and say, well, these are just stupid women who are prepared to work so hard up and down the hills in the heat and the sun for no money. So all these forms of stigmatization undermined the kind of recognition of the project's worth, its legitimacy, the support it got in the community. Sonagachi, on the other hand, was very successful in fighting stigma, partly due to the occupational health background of the project's founders. Sonagachi managed to reframe HIV away from being seen as a moral issue to being seen as a public health and occupational health issue. Prostitution was redefined as sex work, where sex workers were seen as successful and legitimate workers who needed to unite to secure their rights, just like other laborers. Clearly, the very different political contexts framed these different possibilities in relation to stigma. West Bengal has a strong history of trade unionism and the dominance of left-wing parties. Sex workers in West Bengal had access to strong narratives of the anti-colonial struggle. And for them, the notion of poor people or powerless people working collectively to improve their social position was not foreign. This was not the case in South Africa, where the very strong and laudable constitutional protection of women's rights is often honoured more in principle than in practice. And this was especially the case in a remote rural community, where a traditional chief held tight reins on power and was very keen to ensure that the project didn't broaden its remit beyond its narrow health focus. He appointed a trusted headman to mediate between Highvan and the community and to really police Highvan's involvement in the community to ensure that it didn't become political. And also to ensure, because the chief was very supportive of the traditionalist Inkatha political party, he was absolutely determined that the project should do nothing to increase the profile of the ANC, his rival political party. Okay. The symbolic power of the external change agents were very different in each case. Both projects had high-profile advocates, but Entebeni's external change agent was an experienced social worker, and although she came from a wealthy middle-class background with a long-standing network of powerful contacts and exceptional skills and confidence to advocate for the project, she was female rather than male, a social worker rather than a biomedic, and on a 3-year contract to an NGO rather than having a permanent institutional base. By contrast, Dr. Jana in Sonagachi was a medical doctor located within an established public health system. The project came with significant institutional backing and significant funding, and his biomedical pedigree and his government-backed institutional base would have given him greater legitimacy in driving the project's interests forward in all sorts of ways. There was also a stark difference between the two projects in the funders' willingness to see empowerment as a fundable issue. The Entebeni community volunteers had wanted the project, and it was very much a community. It was in the best tradition, a community-defined project. The women got together and they said, this is what we need in order to improve health in our community. And they wanted the project to focus on enhancing the status, confidence, and authority of the health volunteers to do their work and to exercise significant health leadership. But the Entebeni funders, which were linked to the US government, did not see the poor, in their own words, did not see empowerment of the poor as a deliverable of value to the US government. I mean, that's a direct quote. There was strong pressure on the Entebeni workers who were busy and not necessarily that skilled or whatever, to run around ensuring that they met quantifiable targets, such as numbers reached, an increase in HIV awareness measured through KAP questionnaires. Less interested in the project's commitment to health-enhancing social change. On the other hand, Sonagachi was very successful in selling empowerment as a legitimate thing to fund. Its demonstrated impact on biomedical outcomes was a prized source of symbolic status and recognition by funders. Sonagachi worked very successfully to build its public image, and its growing influence on national and international AIDS policy, it's widely regarded as an example of good practice, reinforced the funders' willingness to take grassroots ambition seriously. So the sex work has been astoundingly successful. When funders came along and said, well, we'll give you this money on condition you measure numbers reached and knowledge and attitudes, they said, no, that's not what we're going to do. What we do is try and create contexts where women can pursue their health more effectively. And because it's such a prized project, all the funders want to be associated with it, and it carries that kind of symbolic status. Okay. In terms of material context for transformative communication, for various reasons, Sonagachi was able to give the peer educators small payments, so that not only did it make sex work and peer education more respectable, but it backed it up with kind of material support, which was not the case in Entebeni. In various ways, Sonagachi was successful, so that when women did well in their peer education, it really worked with women to transfer this sense of skill and agency to other areas of their lives. Whereas Entebeni was unable to do that. And I'm sorry, I actually can't see very well. Is there any? I'm battling to see my notes. Would you mind? I just need this light on, really. Thanks. Yeah, I'm sure that will be okay with the slides. That's much better. Thanks. So what the Sonagachi did was to use sex workers' involvement in peer education as a first step towards promoting wider experiences of effective action to improve people's lives. It quickly expanded its activities to address women's pressing needs getting women released from police custody after a raid, mediating in disputes with madams, addressing women's financial security through the provision of micro-savings and microcredit, helping women to get their children admitted to schools, and so on and so forth. And these successes dramatically increased women's confidence that sex workers had the power and capability to bring about change. In Intergoni, by contrast, there was no opportunities for women to export their new experiences of agency from peer education to other contexts. The Sonagachi project was very successful in a range of income generation, microcredit, cooperative bank. It made opportunities for women to save money, to borrow money. They were able to do things like save money to buy homes for their retirement, marry off their daughters, pay their children's school expenses. And in this sense, it was very successful. The project also used its contacts with politicians to get ration cards for sex workers and also voting cards. So it opened up all sorts of real material benefits in their lives. So this increased the status of the project and the likelihood that it would be more successful in empowering people to take control of their health. Entebeni had less success here. I've already talked about the chief's stranglehold on power. One of the aims of the project had been to increase people's access to government benefits, but because the chief was an Inkatha supporter and not wanting people to support the ANC, he was very hostile to the notion of people getting, for example, ANC-funded food parcels and things, because he felt that this would undermine his political status. The project had planned to strengthen links with the volunteers and workers from the Department of Agriculture. For various reasons, this didn't work. And another thing was that in the early stages, the volunteers had said that their opportunities to get paid work, to access services and this and that, were very constrained by their lack of English language skills and literacy. But the project efforts to build these really fell on stony ground, because once these opportunities were provided, the reality was that women were very busy with their own lives and home-based caring and simply didn't really have time to go to literacy or English classes. Okay, so a key project really was the project's failure to resonate with people's economic aspirations, to improve people's economic lives in any way. And I think for this reason, its ability to influence people's health-related behaviors was significantly reduced in a way that didn't happen in Sonagachi. What about relational contexts for transformative communication? Both projects were keen to promote grassroots project leadership, bonding and bridging social capital to support volunteer efforts. In leadership and decision-making, Sonagachi was very successful in gradually ensuring the involvement of women in decision-making and leadership, gradually moving beyond their narrow health worker roles. There was strong resistance to any aspect of female empowerment in Entebeni. The project got mired in pre-existing male-dominated hierarchies, and the head man refused to give up his status as the leader of the volunteers. When the project first started, the chief put the head man in charge, and the idea was that over a 3-year period, he would hand over leadership of the project to the women themselves. But he simply refused to do so. He just wouldn't do so. And because he was the NGO's gatekeeper to the community, they didn't have that much power to force him to do this when he didn't want to. Sonagachi, by contrast, was able to carefully manage power relations. It also was established in a pre-existing context of male power with pimps and politicians and journalists and all sorts of people that had a vested interest in power relations. But the change agent, Dr. Jana, very cleverly positioned the project as being in line with the interests of those holding power. He emphasized to local men that this was a modest health project which didn't seek to change the structure of the sex trade, and that it was in the economic interests of madams, pimps, and landlords for sex workers to be healthy. So by doing so, he managed to establish a project that was run by women from the outset, but by keeping a relatively low profile, managed to build up its strength without generating resistance from male leaders. What quality of alliances did each project manage to build? The Entebeni project was very successful in building strong alliances with 2 NGOs, but these were very small NGOs. In fact, one run by a Norwegian missionary and one managed by a British businesswoman who for some reason had ended up in this sort of strange area. These programs were immediately responsive to the needs of the community. They managed to get small amounts of money to do exactly what the community needed. So if the community was having a big rally, they immediately managed to produce £20 to buy meat for everybody in this. It's very small, very local. And while the project wouldn't have functioned without them, these were one-woman NGOs run on shoestring budgets and not sustainable. Both women were in their late 60s. So this just simply wasn't a kind of sustainable structure to carry the project beyond its 3-year life. And despite monumental efforts, it failed to establish long-term partnerships with local government bodies. At the beginning, there were meetings held with people from clinics, welfare, health, municipality, and everybody was very enthusiastic. They said, this is going to be an example for best practice. We're going to really engage in this project. This is going to be a model for how we engage with communities in the future. But over time, the reality was that this didn't happen. Public sector agencies were overworked and under-resourced. Hierarchical work structures prevented them from being responsive to the needs of small local communities. They lacked confidence in their ability to impact on what they regarded as the overwhelming twin problems of AIDS and poverty. They lacked training in local outreach skills, and many people, civil servants, really didn't have the motivation to engage with poor people as equals, for all the reasons that we're all aware of. By contrast, Sonagachi managed to build excellent productive links with pimps, madams, media, politicians, funders, all of which saw that they had something to gain from project involvement. The city mayor donated municipal land for building a clinic. Good relationships with the media regularly led to good news coverage. As Sonagachi gained momentum, the women's unity and the emerging positive image became an important resource, supporting negotiations with more powerful outsiders. Politicians became interested to support the project because unified sex workers came to represent a potential vote bank. Secondly, they gained positive PR and media attention from being seen to support this highly marginalized group in their city. Police became increasingly willing to take sex workers' complaints seriously, not to abuse them, arrest them, and so on and so forth, because the project could mobilize inconvenient protests, with large numbers of women chanting slogans and demanding fair treatment outside the police station. So the women's strength in numbers became a self-perpetuating resource, which was very useful for the project. Just to make a couple of comments in conclusion, I hope I've started to map out some of the contextual factors that enabled effective community mobilization in one setting, but not the other. And I do think that if we are going to continue as is a pillar of international health policy to see community mobilization as a core feature of health projects, we need to work far harder on looking at how community development projects can create social environments that enable effective community engagement. It's not just enough to focus on building health-related skills in small community groups, or somehow to see that community members are going to provide unpaid assistance to existing health and welfare services. And just a couple of comments, just really in conclusion. I mean, obviously one of the key advantages of the Sonagachi project, which militates against the situation where most of us work with short-term externally funded donor projects, was that the project took a long-term improvisational approach. It evolved in an organic way, built on small achievements. There was a heavy emphasis on empowering sex workers to take control of their lives in general, and not just health, and that increased their ability to exert all the influence that created more in health-enabling social contexts. Enter Bernie, although it was rooted in a long consultation process and in a grassroots organic group, followed because it was you had US funding. It followed a predetermined project proposal driven by the funders' ideals of increasing numbers reached and knowledge retention, rather than wider goals of building communities' capacities to take responsibility for health in all sorts of ways. Secondly, Sonagachi was staggeringly successful in providing incentives for potential allies. It used shrewd incentivizing, a gradualist approach. It captured the personal, political, and economic interests of relevant groups in quite a shrewd, almost calculating way, leading to meaningful support for the project and the women. It showed that the challenge of creating conditions where the poor have voice and where relevant social groups are willing to listen to them may often involve realpolitik rather than mutually respective dialogue, as more progressive theories of social transformation by Freire and Habermas and those kind of people would suggest. I think community projects need to pay far more attention to building incentives for more powerful groups to support the health and well-being of the marginalized. Peer education, as I've said, is the dominant community outreach approach in international social health policy, needs to be far more than the exchange of information and health-related skills. Sex workers and volunteers are not taken seriously merely because they have an intrinsically meaningful or convincing message to deliver or helpful services backing them up. They're taken seriously because they're supported by a symbolic context that recognizes their legitimacy a material context that gives them the confidence as well as a secure base from which to take risks in developing their leadership skills, and a relational context in which their listeners have a clear interest in taking them seriously. Thanks very much.
Okay, well, thank you very much, Professor Campbell, for your presentation. So before we take any questions, we'll go to the next speaker, who is Dr. Lori Newman. Dr. Newman is a medical epidemiologist, trained at the University of San Francisco and at Washington in Seattle. She worked at CDC and has now come to WHO for the last 2 years and is working in the Department of Reproductive Health. So I'll hand over to Dr.
Hi, thank you all for coming today. I really enjoyed Cathy's presentation, and Cathy and I hadn't had a chance to sit down and kind of synthesize our ideas together prior to this, and so one thing that I'd love all of us to do as we go through my presentation is to sit and actually think through. She's presented some really compelling models of how to mobilize communities and what are the key elements for success. And WHO, there's been a big group of people at WHO and other collaborating organizations who have also been thinking about similar concepts, and I think it's a great exercise to do this together, is to think through where do we see some of these concepts come out in what we're doing, and also what are areas in which we could do a better job and pull in some of the ideas she's brought in. So what I'm going to do today is I'm going to talk about mobilizing communities in the context of a real public health context and a program that we're working on right now, congenital syphilis elimination. That's what I was brought here to do at WHO. I was brought here to do monitoring and evaluation, but in a small program what you find is that when there's only 1.5 people, you end up doing all kinds of aspects. And so I've gradually been finding myself looking at how we can strengthen other aspects of the initiative. And this is one of those areas where I really think we could do a better job and be stronger and more systematic and strengthen. And I think in the long run it's going to make things like the elimination of congenital syphilis much more sustainable. So I welcome your thoughts and ideas about how we can take some of Cathy's concepts and apply them to an area that we've been working on actively here at WHO. Let's see. Okay, so today I'm going to talk about 2 different areas. First, I'm going to talk about the WHO framework for the empowerment of individuals, families, and communities, and the conceptual framework that was developed to improve maternal and newborn health. And I'll talk about just one of the many examples of how this was applied, this particular framework and some of the tools related to it. Then I'm going to talk about how this WHO conceptual framework and some of the elements in it have been applied to elimination of congenital syphilis and give examples of implementation. But let me give the caveat in advance. These implementations, these are not WHO-directed projects. These are real live projects that come from countries or come from communities themselves, and so weren't intended to fit a particular framework or a concept. And I think it's helpful for us to look at each one of the examples I'm going to give and think about how we could help each of these programs and programs in the future to strengthen and become more sustainable by applying some of these principles. So the WHO framework on empowering individuals, families, and communities was developed in 2003 by a broad network of collaborators based out of the Department of Making Pregnancy Safer. And it was intended to be a broad framework and a conceptual basis, and it was a chance to systematize and unify WHO's approach to working with communities. It had two main objectives, and the first was to contribute to the empowerment of individuals, families, and communities to increase control over maternal newborn health. And then the second was to improve access and the quality and utilization of maternal and newborn health services. This is the basic framework and what it looks like. Basically, it's all based on, it sits on a basis of work done by another department at WHO, which is the health promotion conceptual basis. And the main components to this health promotion are that we need to build healthy public policies, we need to create supportive environments, we need to strengthen community action, we need to develop personal skills, and we need to reorient to health services. I talked about the aims before, but and basically there are a few priority areas that were identified as being important to work in. We need to develop capacities, we need to improve the quality of services, we need to strengthen linkages, and we need to increase awareness. And then this conceptual framework also gets into some of the many key settings in which we need to do some of these interventions. And then these are some of the strategies that's probably hard for you to read, being education, community action, partnerships, institutional strengthening, and local advocacy. These are some of the strategies that combined will contribute to the reduction of maternal and newborn mortality. So the main points in this conceptual framework, some of the main themes that come out throughout it, and some copies of this document are sitting at the back of the room. The first main point is that there's some very important interventions that need to be integrated into MNH strategies so that we can improve the capacity of women and families and communities to better care for themselves and to increase access and use of services. And to make sure that this is a people-centered approach and that it gets at some of the broader determinants of health, we need to make sure that it's participatory and that and it also engages other health programs, local authorities, women's, and communities. In order to do this, not only the service delivery team, but also the community need certain competencies to be able to do that. And we need to be able to evaluate the contribution of the interventions and some of the work that we're doing. And we need to document these processes so that we can share them and use them in other settings. WHO and many of our partners have developed some tools and guides, but we're still left with some gaps in many areas that we need to continue to work in. So these are the key priority areas for intervention that I mentioned earlier, developing capacities, increasing awareness, strengthening linkages, and improving quality. And for example, in the context of what I do, we need to, fundamentally, to eliminate congenital syphilis, we need to strengthen antenatal care. And using this, this model, we need to think through these different priority areas for our interventions. So if we're going to improve antenatal care, we need to improve the care-seeking behavior of women. As well, we need to also think about pulling in and increasing awareness, not just with the women, but the men and the other influential people in their households. We also need to strengthen linkages, including, for example, ensuring that there are mechanisms for the women to finance and receive their care, including transportation. And we also need to make sure that when they get there, that they are received with quality. And to understand what quality means to them, we need their involvement. And we can't just work in any single one of these areas. We need to be working in all four of these areas to actually be effective. This looks like just like any of your program assessment cycles, and I'm sure all of us have seen endless cycles like this. The one thing that is critical and important about this particular program improvement cycle is that at all phases it involves the community. So, for example, in the preparatory phase, we need to involve the individuals, families, and communities in the preparation to do a true community, participatory community assessment. We need to make sure that it's a joint planning process and that the community participates in the implementation as well as the evaluation. And all of this is happening at the local level. And we feel like this should then drive what happens at the province and the national levels when it gets time to be scaling up and sustaining these activities. I also mentioned the need to build competencies, and I think Cathy talked about this as well as being one piece but not the full picture of what's necessary. But in terms of the arena of building competencies, we need to be working with not only the health sector, but also the community to be building competencies. It's important to have a resource person helping to do this and to think about this and strategize how to go about doing this. It may not even be one of the healthcare, the health trained health professionals within the system. It may be better to have someone who has the dedicated time and energy and focus to be able to do this. It just needs dedication and time and commitment, and it can't just be added very easily onto a full clinician's plate. For example, if we think about what competencies with skilled birth attendants that we might want to work in, we might want to work and look at their interpersonal and intercultural skills in working with women. We need to help them learn how to mobilize communities. We need to help them learn how to advocate. There's been additional work in our Department of Reproductive Health and Research looking at what are competencies, and these are some of the areas addressed in those competencies in terms of training curriculums. We need to also train and look at communities and teach the community members some of these skills and these competencies. We need to improve the ability of people in communities to take care of themselves. We need to improve their care-seeking behavior, and we need to improve things like their birth and emergency preparedness planning. In terms of the monitoring and evaluation of interventions, there's several ways of thinking about this. A traditional biomedical perspective is to say, well, has this all contributed to decreases in mortality and morbidity? But it's not just the outcomes, and those outcomes may be impact outcomes like mortality and morbidity, or there may be process outcomes like services provided. But there's other more difficult things to measure that we need to evaluate and measure. So have we actually influenced public policy? Have we improved coordination between levels? Have we actually engaged and participated and gotten the participation of people in the community? Have we strengthened human resources? And I would argue that right now we don't have as good measures in some of these more difficult areas. I think WHO has tended to focus on some of the first category, and the second category is trickier, and I personally think we need to do more in my area thinking about how to measure this. And then have we ensured that, have we looked to make sure in all four of these areas that actions have been implemented, to make sure that any one of these areas is not left unaddressed. So WHO has a huge range of tools and supporting materials that are based in this area. Many of these are coming from the Department of Making Pregnancy Safer, although departments across WHO have these, and I started adding on to the original 4 or 5 documents that were here, and I started adding on and adding on, and I realized that, basically in all of these areas, people have been working, but and have examples and have different aspects and ways in which they've been working and promoting community engagement, empowerment. But I think we need to do a better job of being more systematic in using these tools and encouraging countries and supporting countries to use some of these tools, and being aware of some of these tools is the first process in doing that. And we definitely have gaps in what we have here at WHO and what some of our major collaborating partners have to offer. I would say that the major area of gaps that has been identified are that we lack sufficient tools to strengthen community capacity for participation. With WHO, it's easier for us to work with health service providers, but I think we need to be aware and look for opportunities either with ourselves or our partners to flesh out this area as well. We definitely need to strengthen the evidence base, and my colleague Annie Portela and her colleagues in Making Pregnancy Safer are actively doing some literature reviews in this area right now. And as well, they're helping to document some of the country experiences. I'm going to just show one example of some of the country experiences. This is from El Salvador, using this conceptual framework in a more of a pure form than kind of the next stuff that I'll show and talk about. But basically, El Salvador sought to implement this conceptual framework. And as a result, because they actively tried to empower women, they actively tried to strengthen links, they were raising awareness and increasing demand for quality of health services from a ground-up approach. And as a result, they had some very tangible measures of success in many of the different areas that I was talking about before. So they actually did change morbidity and I don't have mortality and morbidity, but they have process measures here that they changed. They increased the number of women attending antenatal care. They increased the number of institutional births. But then some of these more intangible things that are harder to measure, but we also need to keep track of and look at and look for. The communities were more vocal in able to voice their criticisms and ask for better, higher quality health care. The facilities themselves had better spaces for women to be taken care of, and women spent less time waiting for services. El Salvador, they were able to get very specialized health personnel out to the rural areas, to the people who needed it, and decentralize some of the services that were offered. And as a result of this very successful program that was initially a pilot program, they've now scaled this up to over 60 municipalities, and they're now developing a national policy on social participation that has a social participation approach that's actually going to be used in other health areas. It's not just going to be used for maternal newborn health. It can be used in other, this approach can be used in other health care areas as well. So then let me talk for a little bit about congenital syphilis elimination. And as I was saying, I was presenting at first some of the general framework here at WHO that we try and use. And some of these principles were put into some of our strategic documents and our strategic thinking, and some of them may not have been sufficiently incorporated. And again, it's good for us to think through how some of Cathy's principles and this WHO community IFC framework, how those could be applied to congenital syphilis elimination and applied in a better context. So basically, I think I would guess that there's probably at least half the room who probably doesn't know a whole lot about congenital syphilis elimination. At the average cocktail party I go to, people say, "You do what?" and the conversation stops and we move on. Or it's "You do what? I thought we eliminated that a long time ago." And yeah, people have been working on eliminating congenital syphilis for a long, long time. It wasn't a specific initiative, but people have been treating syphilis for many, many years. But we still have a huge problem. There's over 2 million pregnant women a year who are infected with syphilis. And of these, over 80% of them, we estimate, this is tough to measure, but we think that over 80% of infected women are either unidentified, they're untreated, or they're treated too late to actually have to avert the bad outcome in the infant. And that's unfortunate because 69% of infections in a pregnant woman will lead to an adverse outcome in the infant. A quarter of these are going to be a stillbirth. 11% is going to be a neonatal death. 13% a preterm or a low birth weight infant, and 20% of infants will have a clinical infection, which is what we traditionally think of as congenital syphilis, all kinds of a wide range of deformities. And this is the kind of information that we spend a lot of time trying to get this information out to the healthcare providers and the healthcare system, but I also think we need to do a better job of getting this kind of information out to the communities in a digestible format. This is intended for this audience, but in a digestible format and an acceptable format, and think about how to message the importance of making sure that syphilis in pregnancy is tested and treated for. These are some recent data showing what the prevalence of syphilis in pregnant women is in a variety of different countries. And basically, the main point of this is to say that there's over 10 countries where there are 10 countries where over 5% of pregnant women are infected with syphilis. And what that means is 5 out of 100 babies are infected with syphilis. And if those babies are not treated, 3 to 4 of those will end up in an adverse, in a terrible outcome for that pregnancy. 3 out of 4 of every 100 pregnancies, and that's an extreme problem, and we need to do a better job of addressing this. The good news is that congenital syphilis is both preventable and treatable. It's a bacterial infection, and so we can change the outcome of this infection in pregnancy. Syphilis testing is inexpensive. It costs less than $1 US for either the traditional tests, which require a laboratory to do, or the newer rapid tests, which can be done by any nurse in most clinical settings. Treatment is widely available. It's penicillin, injectable. It is an injection, but it costs less than 50 cents a dose. Screening of all pregnant women has been found to be cost-effective, even in the many, many, many low-prevalence settings that this has been looked at. So there's no reason to change the message, which is every pregnant woman needs to be tested for syphilis, and if she's found to be positive, treated. And this is actually in the guidelines of most countries. It exists, and the reality is, though, that it's just not happening. However, the other caveat is that you need to make sure that that happens early in pregnancy. It doesn't do any good if you get her at delivery. Many women are missed because of stillbirth, or the infant's already affected, deformed, or it's too early of a delivery. So you need to make sure that we need to really push for a first trimester or early antenatal care visit to make this happen and make this effective. This is the reality, or close to reality as we know it, as at least what's reported by countries. And basically, you can see that most countries, 90% is kind of our target of what we think the acceptable screening coverage should be. At least 90% of women, of all pregnant women, should be tested. But you'll see that most countries really are not there yet. And this is just a sample of African countries that we have data for. But around the world, this is a similar kind of picture. And we're really, it's just not happening. And when you think about the persistence of congenital syphilis and why it still exists, there are so many regions. So this is the classic inverted pyramid, and this is the current day situation, and this is where we're at right now. In the ideal situation, this would look much more like a column. It shouldn't be looking like this, because every pregnant woman with syphilis should have an uninfected baby at delivery. But to do that, it requires that every woman receive antenatal care, and not all women do. That all of them get early antenatal care, and not all of them do. They need to be tested for syphilis, and syphilis testing isn't available in all places. They need to receive their results. Many women don't come back to get their results, or are not offered their results. She needs 3 doses to prevent and to get rid of the infection in her, but only a single dose is needed to actually change the outcome for the infant. And only by going through all of these steps can you ensure that the infant is not infected at delivery. And to do that, there's a wide range of interventions that are important, that can be done to change this pyramid into a column where all pregnant women with syphilis receive the interventions they need so that no infant is infected at delivery. This was very exciting for us. This came out 2 weeks ago in The Lancet, an article about stillbirths called "What Difference Can We Make and at What Cost?" And what you'll see is that they looked at the number of stillbirths that could be averted. They evaluated 38 maternal interventions in pregnancy and identified the 10 most effective. Of the 10 most effective, they rank ordered them. Comprehensive emergency obstetric care could avert the most stillbirths. Over 696,000 stillbirths could be averted. This is a modeling exercise. And syphilis detection and treatment came in second place. And basically, and when you look at the cost effectiveness data for these interventions, syphilis detection and treatment was also one of the cheapest of all of these 10 interventions. The only intervention that was cheaper than syphilis detection and treatment was checking women's blood pressure in pregnancy. So basically you get a lot of bang for your buck, and I think we need to do a better job of making sure people understand what a little bit of money can do, and making sure people understand that this is a tried and true and well-documented effective intervention. So what is WHO doing about this? 2007, been working on congenital syphilis elimination for years, but in 2007 actually put together a strategy for and launched an elimination initiative. And our goal is to eliminate congenital syphilis as a public health problem. Fortunately, we can't eradicate it. Humans are sexual beings, and that would require eliminating syphilis in the general population. And we're not there yet. We can think about that for our next generation. But for right now, what we're going to do is we're trying to eliminate congenital syphilis, which means that we need to screen over 90% of first antenatal care attendees for syphilis, and we need to make sure that over 90% of those who are positive are treated. We have 4 main pillars, and you'll see the elements of Cathy's work and the WHO framework in these. We need to ensure sustained political commitment and advocacy. We think that programs need to increase access and quality of maternal and newborn health services. All pregnant women should be screened and all positives treated, and that underlying all of this, we need to have a very strong foundation of monitoring and evaluation. Put more practically, a practical example using the language from the framework, the WHO framework, example of practical activities would be that we need to raise the awareness of the adverse outcomes of syphilis in pregnancy in communities and with healthcare workers. We need to strengthen some of the linkages, for example, with the PMTCT of HIV to improve underlying maternal child health services. And we need to make sure that the quality of care is acceptable to women and so that it's attractive and usable by women. And underlying all this, there are many different ways that we can be creative, including engaging the communities to help us with surveillance and monitoring. For example, we could develop the capacity of traditional and skilled birth attendants to report stillbirths and congenital syphilis cases. So those are just some examples of how our framework does take into account some of these concepts. If we do it, doing congenital syphilis in elimination, you can't do anything at WHO without mentioning how it relates to our overarching mission, which are the MDGs. And it really does, elimination of congenital syphilis does build capacity because self-care does empower women. It'll help reduce neonatal mortality. It'll reduce the number of spontaneous abortions and stillbirths, which it does improve maternal health. And it will reduce HIV transmission because people with STI are at increased risk of HIV transmission. And it also supports the Secretary General's strategy for women and children's health. The thing about congenital syphilis elimination, it's not a vertical program. There isn't a massive program. There isn't a global fund for us. There isn't a rollback for us. It's just a public health problem that WHO addresses. And the problem with that is that it's easy for it to fall through the cracks unless we have very, very strong linkages. And so it requires linking with all of these areas and ensuring that those linkages are strong at all levels of the system, or it will fall through the cracks, and that's what's happened in the past. Now I'm going to give you some very brief examples of countries and some of the really fine work that they've been doing. And again, this is an opportunity to think about, okay, some of these principles have been applied, but how could we more systematically engage countries? And so for each of us, I'd like to think whether, I'll talk a teeny bit about each of these programs, and each of us should be thinking, oh, have they really addressed the symbolic context of material and the relational context, or are there areas in which some of these programs? And so, for example, in Mongolia, where there is really essentially no HIV, syphilis, about 3% of pregnant women are infected with syphilis. They've rolled out rapid syphilis testing to community health centers, because prior to that, it was a very traditional kind of Russian model of healthcare where you had to come to the laboratory in the provincial or the district hospital for care. And so women would show up at the community health center but get referred for everything. The pregnant women got very little at the community health center and got referred to the central, it's a very centralized form of medicine. But the Ministry of Health is trying to decentralize it, and one of the things it is, they got this, they've trained their nurses to do, and doctors in the community health centers to do rapid syphilis testing. And it was incredible. I was there about a year ago, and it was incredible talking to these nurses about how empowered these nurses felt by having just one small tool be introduced to their clinic. They can, and the kinds of things that these nurses were saying is, oh, it has allowed me to feel like I can offer my patient something concretely here in front of me, because she gets tested and treated right there and then. Many of these nurses introduced community mobilization activities on their own. They suddenly started the problem was now their problem. They no longer referred these women off to an STD clinic or to the hospital. The STI problem was now in theirs, and they then started to see the linkages and the networks in their communities, and many of them, without receiving funding or receiving directives or orders or even training in how to do this, went out and started to mobilize. So initially, the initial phases of the project, many of these nurses were doing this independently. This was a global funded activity through the Ministry of Health, and they've started to do some more systematic and support for this, but the extent to which these nurses on their own engaged the communities was impressive to me, and part of that came from these nurses feeling empowered to take action and change the health outcome of these women. In Brazil, Brazil really feels like their biggest battle is with the men. And so they have a whole ad campaign, and the majority of their ads, and I have a wonderful set of slides from them, the majority of them are actually focused on the men, engaging men, getting them in, selling them. So, of course, the majority of them have a football orientation in one way or the other. You know, here's the baby shoe on top of the football. There's another with a football in front. They're fabulous. And they have a national syphilis control day. They're trying to control syphilis in the general population for many reasons, but partly it's to control congenital syphilis. And they're really trying to reach out. And so a lot of the messaging in that country, they feel like that's one of the ways that they need to reach out and make changes in their and raise awareness. In Argentina, it's a little bit of a softer message. It's all about partners, and I love the el embarazo de los dos, la panza de ella, el embarazo de los dos. It's her belly, but the pregnancy is both of theirs. And it's a softer message about engaging partners and bringing them in, but also effective and appropriate for their cultural context. This is an example from Peru. This is a very new activity. This is a study that was done by Patty Garcia at the Universidad Cayetana Heredia in Lima, and some of our colleagues at the London School of Tropical Medicine and Hygiene, and looking at the introduction of RSTs, rapid syphilis tests. And this is what used to happen. It used to be in Peru, it took at least 6 contacts with the antenatal care system and 27 days before you got your syphilis tested and treated, which is quite not a customer-friendly situation. And in an introduction of the rapid syphilis test, they've been able to reduce it to the first contact, 1 day syphilis testing and treatment. And it's changes like this that make health services more attractive. This is an example of changing the quality of services and making them more customer friendly and figuring out what is it that will make health services more attractive to women. Now, the Cambodia example the Cambodia example for me feels like the one that is most closely related, and this has been going on much longer. And the Cambodia example probably embodies more of the principles that Cathy was talking about than any of the other examples, I would say, in a comprehensive. Cambodia has been looking at, they call it their linked response, and it's not just congenital syphilis, it's HIV prevention and STI prevention. It's very broad in improving maternal child health. But basically, their linked response means they're not only trying to improve the linkages between the different levels of the healthcare system, but also a very important part for them is to engage the community and work directly with community. But they've also brought in NGOs and worked very effectively with the NGOs to for example, the Clinton Foundation, to engage the community. And they have components working with sex workers, components working with general population women and so forth. But the community is kind of a critical piece of this whole initiative. They actually, it's been going on long enough that they actually, this is published in Jade's, and electronically, the print issue hasn't come out yet. But they only recently added in syphilis. They were doing all this HIV tests, and they realized, ooh, for 50 cents a person, they could actually do syphilis as well. And they've increased syphilis testing and HIV testing coverage. In addition, over here, there's no way you can read this, but the blue line is basically what's happening with the number of increased antenatal care visits. And the most recent data that are on here is they're actually staying stable at about 100%. They've increased the number of women delivering with skilled birth attendants in healthcare facilities, and they've increased the number of women modestly who are using contraception. And they haven't spent as much time measuring in publications like this. They haven't spent as much time measuring some of those other softer aspects, but that are harder to measure. But when you talk with them about their program, there are certainly really, I think you would agree that within the country they feel like this has been of such value. And this was originally done in these 2 districts, and now they are scaling up to a national level. These activities. So just my last slide, which is the summary thoughts on this whole thing are basically that We do need to make sure that we are working with individuals, families, and communities to do very concrete public health things like eliminate congenital syphilis. WHO and many of our partners have a wide range of tools to support countries, but I don't think we're done yet, and we need to be more creative and think about what are the tools that we need to make this happen. And I think we absolutely need to be more systematic in thinking about this, because I think this is the only way that we are actually going to make any of these initiatives and activities sustainable. And it's the only way that we're going to truly ensure that universal access for a comprehensive maternal newborn health package. So, thank you.
Of an informative papers. Conscious that we've got about 15 to 20 minutes for questions, and some of which will be coming over the webinar. So I'll open straight up for questions. Do keep your questions short. I'll just ask one question per person, at least initially. And could you use the microphones on the desk if it's possible, just so we can ensure that your questions are the answers all for the webinar.
Thank you. I missed part of Cathy's presentation, so I might ask questions that you might have covered. I apologize. I had two questions, both for Lori and for Cathy. I mean, to me, what I'm not quite getting a handle on is that, yes, there are similarities between what you've outlined, Lori, and what you were outlining, Cathy, through the Sonagachi example. But to me, there seem to be very fundamental differences in principles. The Sonagachi, as far as I know, has had a very different purpose, and that was to not just mobilize communities because of access to HIV prevention, but because they wanted to improve the community's well-being overall. That itself was an intervention, whereas here we're talking about engaging communities by raising their awareness about services and programs, which to me has very different implications. So I'd like to just maybe comment on those differences. And then the question specifically is for Cathy, what do you think are the guiding principles for Sonagachi? I know you talked about the realpolitik and the organic, but there are some very critical guiding principles that were underpinning the whole community mobilization approach of Sonagachi that are important from a perspective of empowering communities and individuals. And can you comment on that?
In terms of saying that Sonagachi aimed to improve community well-being, whereas the types of projects that Lori were talking about were more narrowly focused on health, I think that was precisely the point I was making. Maybe you missed the beginning of the paper, was that the Sonagachi's project started off very strictly as a program to distribute condoms and to promote HIV awareness and whatever. But I think that in working with the sex workers, listening, and the collaboration between the sex workers and the leader, it became very clear that unless one worked to improve community well-being, the more narrow medical goals wouldn't be reached. So I suppose that was really the point that I was trying to make in my paper, is that it's all very well to say that you want to improve awareness and whatever, but unless you do the wider engagement with community well-being, you're not going to succeed. You're not going to succeed because, for various reasons, the peer educator is not going to have the legitimacy. Once people have made individual decisions to be made to improve their health-related behavior, there's going to be huge structural constraints that prevent them from doing so. So I suppose that's the point of my talk, is that there's no point in doing the awareness and the skills building and the condom distribution unless you do the wider context building activities as well. And that's, don't kill the messenger, don't pull a face at me, because in public health, particularly medical people, they say, well, what's the bottom line? And I say there's no bottom line. The fact is that you can't do it unless you do these more soft and extensive activities. And I'm sorry, that's just the way the social world is. I can't take responsibility for that. Because I think that too often, in order to get money, as community health people, we make promises. We say that if we mobilize communities, all these changes will take place, when in fact we already know that in fact unless they're the wider, what Lori calls linkages, and what I call context building activities, unless those take place, the ability for the changes to have long-term sustainable impacts are very reduced. I mean, in terms of you saying what are the guiding principles, I mean, I've written a lot on this because I'm a social psychologist about AIDS competence, that programs need to provide people with knowledge, they need to build safe social spaces for peer interaction, communities who need to have sense of ownership of the problem. There need to be bonding and bridging social capital and this and that. And I do, when I talk to health people, they do kind of glaze over. They say, well, this is all soft and we want 3 bullet points about the way forward. And I think it's because in communities people keep on pressing for those 3 bullet points that programs continue to fail. We're not honest enough or ambitious enough to say that more needs to be done for community programs to succeed.
I guess I would just add on to that by saying, I mean, ultimately, we all want community well-being. Our entry point, we're at WHO or we're in a public health environment, is through public health. That's our mechanism for contributing to community well-being. And I think I was trying to say that community well-being, an entry point, our entry point and our starting point is health and improving health outcomes. But to do that, we need the supportive social environment. And there's, I think it's just a question of what is your entry point for doing that. And we have people at WHO who are working at that from different aspects. We have people working at it from a legal aspect and changing the legal environment or changing, and there are economists and people who are, my perspective as a medical epidemiologist is to start from the health perspective and look at the linkages that way. There will be other people thinking at it, sitting outside and looking at how to make the health connections with health. But I think we all need to be making sure we look at it from different perspectives.
Tell us what you think. Since you obviously think something.
Sorry, I don't want to dominate the conversation. So maybe if you want to give, I can individually respond to where I was coming from later, but maybe others can get a chance to ask questions.
Well, I look forward to that conversation later. I just wanted to make a comment that what struck me the most of the first presentation was the fact that the funder was actually not fully supporting the actual initiative and objective of the project. And I think that if that's not true and that particular funder is looking at outcome or impact outcomes rather than the actual broader component, I think many people in public health will just go after the money and not really look at a long-term strategy. And I think this is perhaps one of the major, if you're going to have a take-home, I would argue that could be one of the major take-homes, that we shouldn't be attracted by a little bit of funding, which doesn't really obtain the objective. But the question I had for you, Lori, had to do with the fact that I was struck by a cost-effectiveness issue of $1 for a test and 50 cents for the shot. Why not, and why has a strategy not been thought of having the pregnant couple just merely both get an injection of penicillin, full stop, and all pregnant couples get an injection of penicillin? Why do you have to test, wait for a testing, it's positive, she gets the shot, then you got to go back to the partner, find the partner, have the partner come in, give him a shot? To me, it seems like the strategy is actually missing the partner even though it's claiming to be getting it. And I just wondered if that strategy had been looked at. Thank you.
I think that I think moving towards universal testing and treatment of pregnant women and their partners for syphilis would have to be piloted and tried somewhere. I think it would not be attractive for a lot of different reasons. I mean, there is a small risk with penicillin of anaphylaxis. It is an injection. It is an invasive procedure. An STI diagnosis is stigmatizing. The other reason is, yeah, the woman's going to bring in her partner, but if you don't ever test, you don't actually, she'll bring in a partner. Is it the partner that she acquired the syphilis from? Not really quite clear. So there's a lot of aspects of STI control that would go unidentified. The other thing is syphilis management is not quite so simple, and it really is helpful clinically to be managing patients that you actually know whether they really did have syphilis or not in the future. So there's a lot of different reasons why that hasn't been done and isn't quite an acceptable strategy at this time. Yeah.
If I can quickly respond to that, that may be true, but on the other hand, your coverage is greater. yes, from your idea of monitoring and evaluation, it messes it up a bit. But are we thinking about monitoring and evaluation, or are we thinking about the patient and the child outcome? So, because you're still going to want to get that partner eventually, because she's going to get reinfected and possibly within the next week. So I think that, and I'm just wondering if indeed that strategy could not be at least attempted, I mean, despite the monitoring and evaluation issue. That's all. Thank you.
I'm puzzled by you saying, well, the project didn't work because the funders weren't supportive, because working in the field of community health, the funders always call the shots. The funders always privilege biomedical over social interventions, and nearly all social interventions will have been done either under the radar or piggybacking onto a biomedically prioritizing project. So, you know, and when one's working in a poor community in deep rural South Africa, the notion that somebody's going to give you any funding, you know, in a completely impoverished state, you take the funding. You don't turn around to the funder and say, well, we're not taking it because, you know, so I think that your comment is idealistic rather than realistic. And the whole issue becomes how to manage funders better and educate funders better. And that's the, I think
would be my argument. That would be my argument, because I also think, indeed, yes, you may be telling the funder no, and you want to still get that money, but then you can't look at that project and say it was a failure, and then say the reason it was a failure was because, if you already knew that it was going to be a failure because you took the money without
well, I can tell the story of this study was that originally, can I have 2 minutes to do this? Yeah. Originally what happened was that the funder gave us the money. They came and visited the community. The American senators wrote back emails and said how touched and humble they were, how they loved the work. The community could do whatever they wanted. So the project went for 18 months, building in an organic kind of slow way. Then what happened was the financial controller in Washington was changed overnight. And he or she suddenly looked and said, yes, but where are the deliverables that are valuable to U.S. governments? And the representative phoned us in a complete state and said, why aren't you counting numbers reaching this and that? And we said, no, because we're empowering. And she then went back to the financial controller in Washington who said, no, cut the funding. And the funding was cut precisely because we did insist that that's what we wanted to do, and that we didn't have the capacity to do those kind of things. So it's a bit of a longer story than we told you.
I had a question for Cathy also, and I very much agree with your comment about how programs traditionally start with either peer education or message giving. In fact, when we did what's called the IFC framework, we have the 4 areas, and what we found was about 80% of programs only fell into that first column of developing capacities, which is traditionally, or advocacy work, which is traditionally what, because donors support this behavior change concept. And to get what we work most with countries now is to help them look at what they're doing and look at the 4 different areas and try to get off of just spending the whole community effort on campaigns and materials and posters, and even peer education in the sense of they contribute, but if you do that alone, will they? And I was pleased to see that in your presentation you've moved away from this language of behaviorism, which again we don't associate with adult education principles anymore, and a number of other things. And as a social psychologist, I would just be interested in knowing, for your theoretical basis, yes, and you know, again, we're pleased that there's been a shift from the behaviorism, at least in your language, and I don't know if you've seen that throughout the literature throughout.
Well, I don't think so. I mean, I think we're sort of a minority group, really, aren't we? Critical social scientists are not the most popular, actors on the block, really. And in some sense, I suppose that this kind of work can be done within universities because we don't depend on funding in order to exist. So we have a luxury, really, of sitting in universities in armchairs saying this is the way things should be. But the issue of translating that into practice in the real world is and I mean, it seems ironic to me because every new document that comes out says community mobilization, and then if you look at the way the project's designed in a way that community mobilization is not understood or prioritized in any way that's likely to. So I think that we almost become the kind of token, you know, it's good to have a token community mobilizer on board, but nobody really takes very seriously the need to have time and funding, whatever, to make that possible.
Just for the sake of kind of clarity, what is it that you're talking about in terms of kind of behaviorism? Are these kind of assumptions that if you give people information, raise awareness, their behaviour
behaviour will change, and it would be sort of they will engage in sort of health enhancing or low risk kind of behaviour. Is that what you're talking about? But
Yes,
then,
yes.
then you backed up to that is that if you've got entrenched social inequities, say gender kind of inequities, then those effects of raising awareness won't happen, or will happen in kind of unintended ways. Just a point for kind of clarification.
Yeah. So that's what did we do historically in HIV? We said that if you want people to change their behavior, you must give them information. And then we said, okay, well, information is not enough. You must also give them skills. And then more critical people came along and said, yes, but unless you create social environments where it's possible for people to act on the basis of that information and use those skills, programs aren't going to work. But in some sense, because that is so difficult to operationalize and to measure, what do? We keep on going out to funders and saying that if you give us money, we'll change people's awareness. And then the funders give us the money and we change the awareness, but we all know before we even start that awareness is quite a weak determinant of behavior change and a lot more needs to be done. So we're all in kind of collusion with the funders in order to get the money, perpetuating this we repeatedly say we'll change your health problem by building awareness, when in fact there's decades of social science that show that it's not the case. So we're all kind of in a trap.
Just to add that it's not the only reason why people don't do things is not because of lack of knowledge. That's one reason, but there's so many other factors that contribute to it. And again, when we start, I'm not saying behavior change objectives aren't part of it, but when you start from the perspective of it's their fault, they don't know, they don't understand what we're trying to do, it definitely changes the way and your openness to what you address in the project, in the program, and this whole part of really making communities partners, and again, not starting from a model where self-mobilization, we're not saying now the government's role in communities should run health programs, not at all. But how do we work together as partners and take it forward? And I think that's what changes the perspective. But behaviorism itself very much relies on information giving as a main instrument for reaching objectives. Again, it's varied and expanded over the years, but if you look at program budgets, that's been maybe a big part of what programs have focused on.
Thank you. I'm Rama Farah, former staff member, and I'm a health historian. So it was interesting to be here and to listen to the recent trends in management of some of these diseases. Well, Lori, this is a question for you. I mean, you mentioned the links that have been developed in the strategy for the elimination of congenital syphilis along with the other programs. And I think that's the right way to go, because when you operationalize this at the country levels, obviously you have to integrate whatever you plan to do based on your evidence and the guidelines with antenatal care and care of the pregnant mother. And that is important in the interest of sustainability, the long term. You can't have a vertical program, and this is a burning issue with WHO right now, whether you have vertical programs for every disease, elimination, or whether you integrate this into a health system that deals with all the diseases. So I would think that given that STDs are mostly appearing in clusters in people, in pregnant mothers and so forth, it might make sense while you operationalize it at the country level that you integrate this into general pre-antenatal care so that you make sure that it's carried out.
And thank you. I mean, I think that's absolutely our main message, which is that basically, if high-quality antenatal, comprehensive package of antenatal care is offered to every pregnant woman, there's no need for anyone to say congenital syphilis elimination. It won't exist. So ultimately, everything we can do to push for a comprehensive package of antenatal care gets us closer to our goal.
I'm Laura from RHR. I'm not an historian, but I'm part of the history because I'm old. And I would like to say that I started work in '78 in Tanzania, and every woman was having syphilis test. You are going now, I was there last year, nobody's having syphilis test. So, you know, this for me is a very bad lesson that we didn't learn. or we learn the wrong lesson. And the same, I think, is with the community. We go there, we do a very nice project, it's beautiful. I have seen hundreds of projects. And the result now, you go in the same village and nothing is left. So I think we are a bit arrogant to think that with the project we change the mind of people. It's a bit what Annie was saying. You can give them all the knowledge, but we don't give them the time. The time, because it's the time that you need to change. So, you know, I don't say that is useless, because the knowledge is never useless. But for example, I didn't hear anything to talk about the education of the staff. That is extremely important. Because, you know, when a patient comes to you, what she or he wants is to be cured. Doesn't matter if you understand or not. A woman, when it comes to antenatal, she wants to be treated. And, you know, this is responsibility of the health staff. And many times we are going there with this very fast in-service training that has no result. For my experience, it's really something that is a lot of money that the donors can show that they have spent. But the result of this, I don't really know.
Okay. Firstly, that clearly it's important to improve services, but my interest, and I think also Laurie's also interested in this, is how to get people to the services in the first place. You know, once the person is there, then it's a... But also in terms of you saying where you can give people knowledge, I think one of the things we emphasize a lot in our work is that what we often do as health professionals is we think that we have the knowledge, that we're the experts. In fact, we're the experts on the medical side, but the community are experts on their lives, on what they understand, on what they're prepared to do and what they're willing to do. And unless we move more towards an ethos of dialogue between health professionals and communities where everybody is seen as having relevant expertise, I think that we are shooting ourselves in the foot a lot. You know, we go in thinking that we know things, but in fact we don't know what's feasible in relation to people's lives. We don't know about people's cultural beliefs. We don't know about a whole range of factors that are going to determine whether people use the services or not. So that for me is kind of something important where we talk about knowledge, giving people knowledge.
And I guess I would say, you know, I spent a lot of time thinking about if people have failed to eliminate congenital syphilis, what do I think now that this is going to change? There's a lot of things that I think, a lot of reasons why we need to change our approach. We need to think about not just a vertical program, but we need to think about health system strengthening, and not just health system strengthening, but community system strengthening. And unless we are all, every single one of us, I mean, everybody has to have an area of expertise, but all of us have to be health systems thinkers. And I think everybody at WHO should undergo like rigorous community and health system strengthening training to make sure that everything we do, we understand the linkages and the connections and look for those opportunities, or we won't. A vertical program is never going to be sustainable in the long term. And I think that's what we have to do differently, is look for all those linkages.
Well, obviously, there's a lot of research that shows that education improves the likelihood that people will make good usage of services. So I think that that's a very good and a very important point that's being made. But on the other hand, I think there are examples of where people without formal education have been able to do all sorts of amazing things to improve their lives. So we, in some sense, while I agree with the comment, we must be careful not to use it as an excuse to hold us back and say that people, it's not worth working with people unless they're educated, because in fact I think uneducated people can achieve huge amounts in their lives if they're given a chance. That's my perception.
Yeah, I would agree and just say it's easier to work with someone if they have a general or a higher level of education, but it doesn't mean that their contribution can't be as valuable.
Thank you very much. So we'll take the final question.
Thank you, Lori and Dr. Campbell. Very interesting presentations. Since we are in historical seminars, I actually was thinking that, community participation and mobilization has been a fundamental principle of health delivery services since the 70s. And there is a lot of experience. It has been clearly indicated in the Alma Ata Declaration 30 years ago that was a critical component of our public health success. And there has been also a lot of opinions about why it has failed so far and why it's not an integrated part, it's not a part of the health services that are being delivered nowadays. And now there is a lot of, renewed interest in this area. So I was very, very curious to know what, in your opinion, are the reasons for that historical failure, and what you think is the key components to keep so we can actually have some improvements.
I think the reason why it fails is it's hard and it's not easy. It's much easier to think about a single issue. It's much easier to be a TB thinker or malaria or an HIV thinker or an STI thinker. It's harder, and many of the people in positions of leadership get there through experience and training in a single narrow area. And I think this idea of network thinking and systems thinking, I don't think enough of us are trained. This is an internal training issue, and I think that we need to do a better job of that. I also think the funding, and this gets back at what you were all talking about earlier, I think the issue of funding, it's also easier to fund things that are vertical and discrete, and there's less patience with funding things that have softer, more intangible outcomes. And measuring empowerment is really hard. And I think what it requires is patience and systems thinking and vision for the future. And I think that the only way around that is to be aware of that. I actually think the Millennium Development Goals were well thought out. They're broad concepts. They divide into areas, but they're broad concepts, and so all these individual areas have to contribute to this broad concept. And I think that's an example of help pushing the public health community to think broader and bigger than we have traditionally done, but it's hard.
If I can just make one very, very quick comment, because I think our time is out. But certainly what the WHO's Social Determinants of Health report has shown very clearly is that in order to improve the health of marginalized communities, there has to be some form of redistribution of political and economic resources and power. That is just a precondition, and I don't think there's any political will to do that. And in some sense, the people that formulate policy, make programs, run countries have a vested interest in the status quo to a certain extent, and that they're political constraints. And that's why, I've just written a paper called Retreat from Alma Ata, looking at how, in fact, there's been a wholesale stepping back from that kind of community empowerment approach, and I think political will is the reason. And the World Health Organization report says that. They say that political will is a very significant social determinant of health, and we need to spend much more time looking at that.
To sum up, history is about continuity and change, and we've seen, implicitly there's been a lot of kind of change in terms of technological advance, but there's been a lot of kind of continuity over time in terms of social structures and political sort of systems failing to be adapted to deliver kind of good healthcare. So I think if there is a lesson from the seminar, it's that lesson. But these conversations will continue in this room for a few more minutes and in the coffee house if you'd like to kind of join us. And I'd like to put our hands together once again to thank the welcome Chris and Cathy.
I just was going to introduce Dr. David Clayton from the University of York, who was chairing the questions. University of York is one of the sort of co-organisers of these seminars. I just wanted to acknowledge that. Thank you.